Okay, I just want to confirm also that you can see my slides moving.
Yes, they're moving.
All right. So I think we can just go straight ahead and start. I think a number of people have already joined, and in the interest of time, I'll go ahead and begin. So thank you all of you for joining us this evening. This webinar is in recognition of World Arthritis Day. World Arthritis Day is usually celebrated on 12th of October, but because it fell on a Sunday, we decided to have our webinar this evening, which is close enough to the day. So World Arthritis Day really is in recognition of the patient population, patients who live with musculoskeletal diseases. Today we wanted to focus on our healthcare workers and give two topics in celebration of this day. So there are two speakers today. My name is Dr. Nakitare. I'm a rheumatologist at Kenyatta National Hospital. And my co-speaker or co-panelist is Dr. Eugene Genga. He's a rheumatologist also from the University of Nairobi, and he also works at Kenyatta National Hospital. So we have two topics today. And the topic that I am presenting is just to reflect on matters to do with adherence. And I selected this topic again because today is World Arthritis Day, and I wanted us to think about the perspective of the patient, while Dr. Genga will give us a didactic lecture on a specific disease, which is osteoarthritis. So I'll move into my presentation. And maybe those who have questions or any comments can, after the presentation, let us know. So what I want us to reflect on today is the other side of the prescription, which is to do with adherence and compliance. And because rheumatology is a chronic disease, meaning that our patients expect to take many of our patients expect to take their medications indefinitely or lifelong, in the same way that other non-communicable diseases have their patients take medication for that amount of time. So to open, I'll mention three cases that we've come across at Kenyatta National Hospital. So have a look at this slide. The first patient I'll mention is a patient who was male in his 20s. A few years ago, it could have been about 3 years ago, maybe 2 years ago, we admitted this patient into Kenyatta National Hospital, and he stayed with us for a long time meaning for months. And his diagnosis in the end was lupus, with lupus nephritis, but we also treated him for TB. He had multiple abscesses in different parts of his body, including the spine. So he was at some point treated for TB. He stayed with us for a long time, and we finally stabilized him and discharged him on appropriate medication. But unfortunately, he was lost to follow-up for at least 1 year. And by the time he came back to us, he already had other organs failing, including his kidney. So he had kidney disease, he had heart failure with reduced ejection fraction, and he also had the symptoms of a flare of lupus. When we tried to explore why he had not come to clinic all this time, he gave a mixture of responses, the first one being financial difficulties. And he said that he also, well, he kind of felt better, stopped taking the medication, and because he didn't have money, he continued with his life. The second patient I'd like us to consider is a female who is in her 30s, who is followed up as an outpatient. And this patient has lupus with neuropsychiatric symptoms, and some of her neuropsychiatric symptoms would be considered in the range of psychosis. The challenge with this patient then that I want to mention is self-management of medication, partly because of her neuropsychiatric symptoms and partly because of concerns about adverse effects of some of the medications. And so this patient sometimes varies the dose or decides when to take, when not to take, skips sometimes. You prescribe a BD dose, you find the patient is taking an OD dose, and so on and so forth, or hasn't taken some drugs for a while. And then the third patient, again, I'd like us to consider was a female in her early 20s who is unfortunately deceased. And this patient also had lupus nephritis and eventually it developed end-stage renal disease, and several complications came together and contributed to her death. Some of the factors behind this patient included suboptimal dosing, and suboptimal doses can also be a healthcare worker issue, that we can suboptimally dose some patients or give them lower doses. Perhaps even healthcare workers have their own fears about dosing medications. There were also some issues about hesitancy of a caregiver. I'll mention here that she's in her early 20s, and many of us in our late teens and early 20s are still dependent on parents. Not all, but a number. And I think the caregiver also remained hopeful, hoping that delayed escalation of treatment. So I wanted us to reflect on these cases as we speak about the topic today. So adherence. We talk about adherence, we talk about compliance. And I think the World Health Organization suggests that adherence is the degree to which a person's behavior corresponds with the agreed recommendations from a healthcare provider. Is there a difference between adherence and compliance? It is thought that there is a difference and that the word compliance is less in favor now. Most people prefer that we use the word adherence. Compliance being more of, has this patient followed the instructions? So it is more of an obedience description. It is more of, there were some instructions given, there were things that you were told to do. Did you do them? And that's it. But when it comes to adherence, it is thought that adherence encompasses a number of other things to do with assessing this patient, making your recommendations and suggestions, and considering the patient's situation, considering the patient's opinion, lifestyle, and so on and so forth, and then working together to come up with a treatment plan. A lot of patients with chronic disease estimate across the globe is about 50%. It may be more, it may be less, depending on the context and depending on the study and the study design and so on and so forth. But the general consensus is that at least half of our patients who have chronic illnesses are not taking their medication according to what we healthcare workers think they should be. And this is a problem, considering the number of chronic illnesses that we are dealing with right now. What's the problem then with not being adherent to medication? The problems can affect the individual, but the problems also affect all of us at community level. I'll use the word community here because anyway, that word is commonly used when talking about healthcare in Africa. But I know that in the West and other countries, the word community sometimes can sound like a very third world. A very third world. A community sounds like a villagey, rural description. But here I'm just using it to reflect what adherence, of how adherence affects the rest of the people around this individual. So this individual, of course, who is not adherent to medication will end up being their health will be negatively impacted. They will experience morbidity and may experience mortality if it is a disease that causes disability, as is the case in many of the diseases we manage in rheumatology. Then this patient will be affected by non-adherence. But when you look at it globally, we need healthy societies. Whatever business that we have to do in the world, we need healthy societies to drive families, to drive countries, to drive economies, to do whatever it is that we think we need to do. We need healthy society. So when people are not adherent to their medication, then you have more of an unhealthy society. But this unhealthy society, remember that the diseases can be communicable and they can be non-communicable. And what are the consequences of non-communicable diseases? We know of communicable. We know from not so long ago, we were battling COVID. We know from HIV, we know from TB. We know from all those that if people don't take their medications, if people don't get their vaccinations, we know that we've tried to eradicate polio, but every now and then a case here and there will appear somewhere because of non-adherence to vaccination schedules. We need to remember that resources on the individual and the countrywide, at the countrywide level will be affected by this. This person who is not adhering to medication will keep on going back to the hospital at some point. Their resources will be depleted. The family's resources will be depleted. Though here at the individual level, I must mention that sometimes the treatment itself is expensive for the individual and already depletes resources. But now we are saying that now if you're not taking your medication and there are consequences, then again, you'll have to dig into your resources to sort out the consequences of that non-adherence. Case in point, some of our patients start off as, let's say, lupus, and they start off with normal kidneys. They start off maybe treatment for lupus nephritis. If there is non-adherence to medication, whatever the reason may be, they may end up on dialysis. And dialysis is quite an expensive disease, whether directly financially or indirectly. It's thought that at least 10% of hospitalizations are because of people who have not adhered to medications. And remember that somebody who has not adhered, you may not even know that the patient has not adhered to medication, and you may assume that your own treatment plan was not working. And so on the individual level, this issue of unnecessary investigations, you now want to find out more about why this medication is not working. You do more MRIs, you do more CT scans. I'd also like to mention some individual patients do not at the beginning confess that they've not been taking their medication, which takes you down a winding path. You go down the rabbit hole not knowing that this is just about not taking medication. You escalate medication unnecessarily. This patient perhaps would have managed on the first line medication, but because you didn't know, you send them into more expensive, less available second lines and so on. And of course, now this healthcare worker will have to keep on dealing with this patient. And you can sometimes find that the healthcare worker can be frustrated. We also seem to stigmatize the individual. And you sometimes when you're doing the ward rounds, oh, this patient has not taken medication, is non-adherent, and they end up being boxed into a section, and healthcare workers may not concentrate on them as much as they should just because they've been labeled as non-compliant. Of course, the risk of mortality doubles, and so on and so forth. So there are many consequences of non-adherence. So let's look here at some of these factors that are related to non-adherence. They are said to be overlapping. And I just wanted to mention that when you're looking at non-adherence, this is one way of looking at it, as the table is here. And there are many ways and many directions from which you can look at it. But remember that the first way that there can be non-adherence is that you can give a prescription, you can give some instructions, and the patient just doesn't pick the prescription, or doesn't go for physiotherapy, or just doesn't do what you've suggested should be done. So that's one of the things you need to consider. But once the patient takes the prescription or starts off with the treatment, then you ask yourself, why isn't the patient persisting? So what is the reason for non-persistent to this medication? And sometimes the reasons for non-persistence can be intentional or non-intentional. It can be unintentional for those patients who just don't have the money, don't have the resources, don't have access, and so on and so forth. But it can be intentional. And remember, you've met these patients, and the truth is that we as healthcare workers, we are these patients. Many of us who have treated our fellow doctors, our fellow nurses, our fellow clinical officers, and so on, sometimes we end up in some sort of exchange where the patient, who is a healthcare worker, starts to now try to control the direction which we shall take, might decide, oh, I don't want to take this drug, I don't think this is going to work. So these beliefs, these attitudes, these thoughts, some may decide I'm going to be taking every other day, or I'm going to be taking once a day. Or they might decide when I feel like this, I take my prednisone 3 tablets, and then after that I reduce to 2, or I reduce to 1. Or I decide that I've measured my blood pressure today, it's normal. Okay, I'm going to stop and wait for the blood pressure to rise again. I mentioned high blood pressure because I realized that as rheumatologists, we actually do see a lot of high blood pressure undiagnosed. And so I think it's important for us to also consider that we manage many other chronic illnesses other than just the musculoskeletal one. So let's look at these tables quickly so that we can reflect that we have, of course, socioeconomic problems. Does somebody have money? And then these health insurances in Kenya, from SHA to the private ones, what's working, what's not working, co-payment, just stressful, or refusal to cover this, refusal to cover that without good reasons, not being confident. Low socioeconomic status can also affect your confidence in dealing with the healthcare system and not insisting on certain things. Language barriers, health literacy, issues about the patient, age, caregiver dependence. Do I think this treatment is working? Especially chronic pain patients may tend to say this isn't working, and they move on to other things. And how motivated are they to try and work on their treatment? How complex is the medication? We've seen prescriptions of 14, 16, 17, 18 medications. How do we expect this patient who may be 78 to deal with such a long prescription? Some of the drugs are weekly. We know that we give methotrexate weekly. Some other drugs are given in the morning. Some other drugs before you eat the PPIs. Some other drugs we're saying at night. Some other drugs, QID. How do you even take QID? Even we ourselves who are healthcare workers, things like that. And things about side effects. These asymptomatic drugs, I'm feeling better, I stop, or I'm not feeling anything, and other reasons like that. So we are advised to look at our patients and think about some of the things and identify those who are at high risk of adhering poorly, though I don't know whether that really makes sense, because many patients, even patients that you do not expect not to adhere, you can be surprised to find that they're not adhering to medication. So I think the concept of adherence is a very complex issue, and we need to approach it with the complexity. And so the solutions also should be as quote unquote complex, or they should be like a toolbox or a toolkit of interventions that we need to think about. So does this patient have psychological problems at the onset? Is there cognitive impairment, our elderly patients? But even here, think about your children who are also depending on adults, and some of those adults themselves may have mental health problems and bring their own issues. Elderly people also have caregivers who are also can be crazy. You can have relatives in Germany, relatives in Canada, and you're dealing with all that mix of things. Asymptomatic diseases, and that patients are less likely to be compliant when they are feeling that they are well. Do we discharge and follow up well? Case in point, discharge summaries that, especially coming from public hospitals, but I think even private hospitals may have the same problem. We don't give the right information. We don't explain to the patient, and we end up losing there's miscommunication, side effects, belief systems, insights, and the relationship with the doctor. That patriarchal or paternal way of dealing with patients might create a barrier and reduce the ease of communication. People missing appointments. We've talked about complexity of treatment and cost. Cost is a major issue in our society. Other things that I think that may be covered here, but we can mention in our discussion or our thoughts is the issue of, are these drugs available? In our public hospitals, you can write maybe a prescription of, let's say, 5 medications. When they go to the pharmacy, maybe 2 are available. Maybe you've given a prescription that includes some fixed dose combinations. They don't have those fixed dose combinations, and they affect your plan for helping these patients to adhere. There are other problems in pharmacies out there. Who is sitting in pharmacies? Who is explaining to our patients? Do they understand anything themselves, the ones who are at the desk prescribing? So all these things are things that we need to think about. So as I move to here, I just want to mention, of course, that how we assess adherence, it is a difficult thing to do. You can decide to, of course, we've done DOTS for TB medication. We all know about that. But remember, even DOTS, if you look at the disadvantages there, that someone can just hide the pill somewhere, or they can even induce vomit. They can do all sorts of things. You can try to measure the level in the blood, but who has the money for that? You can do questionnaires, but beware that patients may not be honest. They may feel that they need to please you. And so a concept of white coat adherence has been described, where sometimes the patient just tells you what you want to hear, or when they know that their clinic appointment is coming, let's say a patient with high blood pressure might become adherent to their medications just before the appointment and for a short while after the appointment, and then go back to their usual or if you count pills and they know that you count pills, those who have done HIV care and treatment, you can be given the perfect pill count. And then later, maybe when the patient passes away, the wife comes and tells you, oh, I found all these unopened bottles of medication in his cupboard. So there are all these complex things that affect us as patients. Stigma is an issue, of course. People who have illnesses that are stigmatized may find it difficult to take their medication when required. There are these other suggestions about counting pills and seeing how often a patient refills, and all these things are affected by how clever, quote unquote, the patient might be about it. Even these electronic medication monitors, ways of putting smart covers where you open and something registers that the patient opened and removed a drug, but you don't know how many drugs the patient removed, or did the patient even swallow after removing the drug, and so on and so forth. You can hear they've suggested the physiological markers like, you expect bradycardia with a beta blocker, but again, how many drugs do you have physiological markers for? And so there are all these ways that you can measure adherence, and we can think about all of them. So as I bring this to, as we come closer to closing the discussion, what can we do for us who are in Kenya today and we are treating patients with chronic illnesses, particularly patients who have rheumatologic problems, musculoskeletal problems, low back pain, osteoarthritis, fibromyalgia, rheumatoid arthritis, these day-to-day patients that we see all the time. How well do we do what people call the traditional methods of improving adherence? Do we even have educational materials developed locally by our own societies? It is a challenge to us as a Trauma Society of Kenya, and it is a challenge to all of us to develop easily used educational materials that we can give to our patients. And of course, this also requires financing, and therefore that means the government and other people have to be involved. Do we do check-ins? Do we try to find ways to remind our patients, to tell them to buy maybe pill boxes, to have diaries, and so on and so forth? Do we motivate them to be adherent? Do we develop the relationship between ourselves and our patients so that we can have a trusting, we can have trust between us, and they can actually just tell us frankly, doc, listen, I've not been taking my drugs, and we need them to do that without feeling that we are going to quarrel them in a way that makes them feel like children or like they've sinned, something like that. And of course, we need to improve community-wide literacy because sometimes community-wide literacy is helpful. I suppose sometimes when we have patients who come and tell you, do for me cholesterol, do check my prostate, that is because of community-wide literacy. Someone has told them somewhere. There are some members of some communities who tell you, do for me vitamin D levels, because they already know that the vitamin D levels might be low, and so on and so forth. So those literacies can help to improve how we interact. Here, there are suggestions on this table on the left for what we can do. And I think these ones, we can do this. We can identify that poor adherence. Is this person missing appointments? Are they not responding to medication in a way that you expect that I've given them the right medication? I expect at the very least some response, but I'm having a patient here who is not responding at all. Let's ask ourselves once or twice, is it just the lack of, is it the medication, or is it the patient who is not taking? We can question them just gently, what are your challenges? And then we can give them, explain that when you take like this is what you'll get. And maybe try not always to be threatening that, that unataka kwenda dialysis, or, threatening somebody that you're going to be in ICU or something, but just to tell them that this might improve in the long run and all that. See what the patient feels and make our instructions as clear as possible. And I think here about medication, I think we need to work with pharmacies and see who is sitting there and whether they understand. And then medication taking systems, which are many different things like these pill boxes and other things, and try to see what the patient needs, see if they have good family support, and continue to just encourage them every time, and look into, what kind of medication, design your medication, fix those combinations, try to calculate and help them to see, you can take these ones in the morning, you can take these ones in the evening, try to do this, try to figure out the medications with long half-lives. Yeah, these flucloxacillins of QID, you know, can you look for something better, and injections and all that where it's possible. And we know that people are trying to really develop what we call drug delivery systems that help with this. You've had perhaps when you interact with the drug, the partners in the pharmacy, they tell you, in the pharmaceutical industry, they tell you, oh, we have this extended release, we have this and that. Of course, you have to do your own research and make sure that what you're being told is correct, but it's trying to find out what works for this patient. There are some patients, it is said, even in like cancer patients, there are some of them who, if you could find an oral medication rather than them coming to clinic every week or every 2 weeks for some chemo infusion, they would appreciate if we had oral options for them. There are other patients who will tell you, I'd rather just come in once a month for an infusion and never have to swallow anything. We know that in osteoporosis, some of the drugs have been developed. There are some which are weekly, there are some which are monthly, there are some which are once a year. So you need to see what can I get for my patient that can help them to, but with this technology, I think people are continuing to develop the drug delivery systems that improve adherence, and that is the technological part of solving a problem that is very human. And so lastly, we as healthcare workers always need to remember that we must participate in the politics of health, because health is a political issue. It is a national security issue. It is a political tool, and it is valuable to politicians play around with health because it's so emotional and so it gives returns depending on how they manipulate it. So we as healthcare workers, our job is to always make sure our voice is heard so that the politicians do not take advantage of the population for their own to advance their own careers. The health system has to be strengthened for us to accomplish any of the things that I've discussed today. And we know that the healthcare system in Kenya at the moment, really the public health system is broken. It needs a lot of work. And those of us who are in positions of influence should participate in that. We should challenge our leaders and demand good leadership and governance at every opportunity that we have, and participate so that we can protect our patients. So this is what I wanted to discuss today for World Arthritis Day. And I want to go ahead and remove my slides as I invite Dr. Genga to share his slides for his talk. I'm just going to look into the Q&A. There's this request for slides. I think maybe Mwenda and the team, maybe you let us know how we can get slides to you if that is what is needed. So I'm now going to introduce Dr. Genga since I'm the first one who spoke. Dr. Genga is my colleague. He's a rheumatologist at University of Nairobi. He'll discuss his topic on osteoarthritis. Dr. Genga, karibu.
Thank you, Dr. Nakitare, for such an excellent presentation on adherence. Lots of flesh on land. And I think many is actually going to be bothered on that talk also, because OA is a disease whereby we also have to be on a long-term treatment plan. So at the outline, we'll do a bit of epidemiology of OA. What is the impact of osteoarthritis? What are the new insights in pathogenesis? We'll discuss something small on obesity and its paradox. So basically, we look at how to look at this old disease in a new way, not just the boring old wear and tear disease. So OA, as the introduction, it's a serious and progressive disease associated with pain, decreased physical activity, functional limitation, physical disability, and overall health quality of life is actually poorer in this subset of patients. In terms of morbidity and mortality is actually more, especially patients who have symptomatic knee OA. In terms of the overall burden, the prevalence is generally high with ladies. We've noticed that over the last few years, there's been an increase in the numbers of patients who have osteoarthritis. There's one particular paper done looking at OA last year that reported that in the last 30 years, there's been an increase of close to 132.2% over the last 30 years. And currently, it's the seventh leading cause of disability. And part of the reasons why of the increase in the surge of the numbers is the obesity paradox. the BMI has actually contributed 20% of the prevalence rate of osteoarthritis. In terms of the burden and its impact, it's associated a lot of absenteeism and presenteeism at work, partly due to the moderate and severe joint pain associated with the disease. So in terms of epidemiology, usually I like to look at Kenyan data because sometimes you usually think that there's nothing in Kenya. This was done by one of my very good friends, Abdi. Abdi is a physician in Somaliland. Somaliland, there are two types. There's Puntland, and there's one where the Mogadishu, the lower side, is in Puntland. He did a very interesting study looking at the patterns of arthritis. He looked at knee, hip, and hand in patients attending various clinics in the Kenyatta National Hospital. He looked at the clinics. At that time, we had the orthopedic clinic and the rheumatology clinic. He had a sample of about 200 patients, and majority of the patients had knee osteoarthritis, followed by hip, hand, and combined hip and knee were about 5%. Something that he noticed that a lot of the patients were actually obese or overweight. So you can see the obesity paradox is back again here. And I think some of the observations made from this particular paper is that obesity potentially play a role, especially in the pathophysiology of this particular disease. Another paper done at another referral hospital that is now MTRH. The sample size is almost roughly the same, about 170. Mean age about 41 years. But for this one now, most of the patients actually had more hip 35%, knee at 24%, bit of spine and ankle. And they did closer and looked into the risk factors associated with the patients who had osteoarthritis. And they found that people who are advanced age, meaning elderly, female patients, cigarette smoking, alcohol consumption, those with a positive history of osteoarthritis, or those engaged in a heavy physical activity, actually had a chance of getting osteoarthritis. To network to our patients, are some of the things you should be looking in terms of the history taking. And the impact was that it led to that a lot of the patients presented had severe pain and a lot of high-grade distraction and function limitation. And that also had to high BMI. Again, the obesity paradox was back again here. So in terms of risk factors for OA, knee OA, former athletes, we came up with a very interesting paper that looked and showed that people who had previous meniscal injury or some sort of surgery had increased for knee osteoarthritis. Atopic diseases like asthma had increases for OA. In terms of obesity, again, back again, but obesity was very interesting. Just apart from the bearing that we know happens with the osteoarthritis, also associated with hand osteoarthritis. It makes you think that probably there might be more about obesity in this particular subset of patients. So in terms of the etiology, injury trauma is somewhere there, obesity, which we'll discuss later, and the inflammatory mediators. And actually, right now, the current thing is that we should avoid considering OA as a wear and tear, but rather something OA with wear and tear, but also as a progressive inflammation. People with advanced age, overuse, get a bit of like athletes, teachers get the neck issues, athletes get the hip issues, the knee issues. Genetics plays a role here. Gender, more in ladies. Those are some of the factors that are associated with development of this particular syndrome. Like I said, the current thing is that we should now move forward from the boring old passive wear and tear disease and actually be an active, dynamic disease affecting the whole joint. So there have been some papers tried to look in terms of the inflammatory pathway involved with osteoarthritis, and they've been able to identify certain pro-inflammatory cytokines that are very predominant in these particular joints. For example, interleukin-1 beta, TNF, interleukin-6, interleukin-17. And this also drives in terms of the pathophysiology for OA. And thereby inducing an inflammatory cascade, thereby worsening the osteoarthritis. So if you look at this schematic, we have a healthy joint and we have one with osteoarthritis. As you see with a normal joint, very nice calcified cartilage, bone, synovium, everything is pretty nice. Vis-a-vis on this side with the inflammatory markers, first thing you notice that the osteoclasts actually increased there. Apart from that is erosion, hypertrophy of the chondrocytes. Apart from that, also we have vascular infiltration as a result of the inflammation that is there. Damage in terms of the visceral lesion and the osteophyte formation. As you can see, all these come together in terms of worsening the osteoarthritis. So when we look at osteoarthritis, we should avoid looking at it in one way, like the fact that what like Terry said, that a lot of patients have other comorbidities which are often undiagnosed. Like she had the example of hypertension. So we have a number of papers that have looked into some of the comorbidities of OA. Hypertension, very prevalent, 50%. Dyslipidemia, back pain issues are there. Thyroid disorders, depression, we even have some papers done locally. Peptic ulcer disease, potentially because of the increases of the NSAIDs. Diabetes, coming with the weight issues. COPD, asthma. That has been found to be associated with increased risk of OA. Heart disease, an association, though small, but has been found to be associated. A very nice study done by one of my senior colleagues, Juma. He did this some times ago. He looked at cardiovascular risk factors of patients who had symptomatic OA in the knee in Kenyatta. And as you can see, hypertension was also there. Diabetes also there, the numbers there. But obesity, overweight, just as similar to what Abdi had found in his paper, found that dyslipidemia was also seen in this particular subset of patients. So when you look at these patients, it shouldn't be just be giving them the painkillers. They should always look in the patient totality and look for other comorbidities the patient might have. Another paper done by one of our colleagues, Bosire is in Kisumu. She looked at depression in OA, and actually she found a number of the patients who actually had depression. Majority had a bit of mild, about 20%, about 5% had about moderate and severe, but she found that people who had a higher BMI, OA had more risk for depression also, and also employment. Employment status actually, if were unemployed, they found that most of these patients who had higher symptoms of depression. So I think the take-home message from this particular slide is that when you look at the patient, like what Dr. Daktari has said, should the patient totality, having open conversations and avoiding just the usual, are you taking the medicine, or try and find out if they're not taking the medicine, is it probably depressed? Some of the things you should look into this particular subset of patients. In terms of obesity, obesity is something which has been around for some time. And I think the old thinking was that obesity increases the risk for OA by, especially the weight bearing, which are basically the knee and the hip. Though now we've come to learn that potentially it can also put you at risk for developing other sites, especially the non-weight bearing, like the hand. And earlier the term was that there's a sort of micro damage repair with bearing decompression, continuousness, and degradation of the cartilage. But now we come to learn that potentially there may be an inflammatory component that might be also be associated with the obesity. If you look at this particular slide, a very nice paper done some time ago. As you can see on the left side, we have a lean person. The right side, we have an obese person. So I think the first thing you notice at the macrophages, there's M1, M2, M1, M2. So the M1 is more of pro-inflammatory, M2 is anti-inflammatory. In the obese people, they are more of the M1 macrophages, which sets off an inflammatory cascade. As you can see on the right side, the TLP1s are more, interleukin-17 are more, TLP2 regulator cells are more, and this all leads to some sort of inflammation that drives the disease. So when you look at the obese person, it's not just the wear and tear. Potentially, there's been some the change of the macrophages from the M2 isomer to the M1. Thereby, this may be driving the inflammatory process in these particular patients. So I think we'll skip this. So we'll come to a case. 64-year-old lady has come to see you with bilateral hand and left knee pain for about a year. Quality of life is affected. She has pain, can't do much walking, affects her work. Going upstairs is a challenge. What you notice is that she's obese, BMI of 35, and she has comorbidities, hypertension, hyperlipidemia. Currently, she's on losartan, amlodipine, ibuprofen, and acetaminophen. So in terms of explore further in the social history, I think one of the common misperceptions that patients will have that if I'm able to walk around, do my work at home, I'm medically fit, but a lot of them don't do actually exercise. They're supposed to break sweat, which might actually be more beneficial for the patient than just the normal exercise routine, a normal work routine that they do at home. So for this particular patient, little exercise outside work. She has no alcohol, no tobacco, so she considers herself healthy because of none of those. She takes her two fruit vegetables per day. When you examine the lady, the features are more considered OA, affecting the hand, and more prominent on the left knee. So when you talk with the patient, you start with the usual conversation, or you start with exercise, weight management, strength training, educate them a bit on the OA. But like what Mike said, having open conversation helps a lot because We do know the benefits are there for losing weight. There are a number of diets that are available for the Mediterranean diet, the ketogenic diet. A number of studies have shown that losing weight is beneficial for the patient. But what we have to understand that each patient is different and one size does not fit all. So consider that the severity of obesity and OA is different in patients, but so preferences, diet, exercise, all that, and even age, all play a factor. So having an open conversation, because this should be a shared decision making between you as the clinician and the patient. So I came across a very interesting paper done by Hall in 2020, where he actually looked at barriers to starting and also facilitating weight loss. And he found that, yes, we have the benefit. It actually helps improve pain control, quality of life, and all that. But very interesting enough, they found that a number of patients find it very difficult to initiate and maintain it long term. So talking about it is not more than enough. You have to have this open conversation with the patients. And actually, they found that within 2 years, people had lost more than 50%. Actually, they gained back most of their weight. So you can see there's a bit of challenge there. So the having an open conversation again comes into play here. So patients always have very unique variants because imagine telling a show who's like 75 years old, BMI maybe 35. Okay, now you have to start working out on a gym, and she's probably wondering, my knees are given in, my back has given in. So those are some of the things which you really need to have an open conversation. The patient, remember that the obesity is affecting the movement, the pain is affecting the movement. Sometimes even people are a bit shy about just doing exercise. One of the patients told me that I look like a madman, a mad lady, sorry, walking around the neighborhood that I'm doing exercise, and she came from an upcountry place. So she thought she was a bit shy about participating in the exercise. So in terms of how to start it off, simple things, walking 3, 4 days a week. If you're able to break sweat better, 30 minutes. These days, there are smartwatches. If you can target 6,000 to 10,000 steps a day, that would be perfect. At least starting the mobility part becomes easier, especially with the guys who are a bit obese and everything. Walking, cycling helps. Things you can do are things like the aerobic exercises, which are low impact, strengthening a bit of weights here and there, because a lot of the joints that are affected, the muscle around the joint become actually weak. For example, patient will tell them whenever the knee or a patient will tell when they walk at a very fast speed, they feel like my knee gives in. So the knee gives in because the thigh muscles, the arms, the muscles, everything are not strong enough support. Things like yoga. Before I used to wonder this, but actually yoga helps a lot in terms of flexibility, the stress that comes with the disease. Tai Chi, something they can use for balance. And these are things which can be very simple and incorporated. For me, I tell my patients go to YouTube, just find something there. Is it disadvantage you can direct them what to do? You may never, for the older people who may not be that tech savvy, you involve now the younger, maybe their daughters or their grandkids, you can take them through these particular sessions. So as a general guideline, we want weight loss is not the easiest, but at least losing 5% goes a long way because of the 5%. Slowly then as you get better. Bariatric surgery can be considered for patients, especially the BMI of about 40. These are options you can talk with the patient. But I think starting having an open conversation, diet restrictions and exercise, until I'm making what you have for the patient and thereby be able to get the best out of it all. So in terms of guidelines, I think the talking about this slide is just again, like what Dr. Nakitari said, these are long-term illnesses. You have to have an open conversation. Because she gave a very good example where you have a patient X, like she would probably have a relative in America, another relative in Australia, and they just pump them with those supplements. They don't know what exactly is there. Tell them this is not important. So there's a lot of consultation. So you do sometimes a bit forced to have actually conferences in the office whereby you have supplements all over the place talking, and you have to have an open conversation talking about what the patient has and what is important for them, because their interests are good. But sometimes you forget that, for example, the patient X has hypertension, diabetes, cholesterol issues, then has arthritis. That's a lot of pill burden. And they're more likely to take they'll probably be told, if you take the herbal stuff or the supplements, they're safer than taking the other standard medicine. So when you choose the medicine, also that would be very important in terms of playing around with what to give the patient for that particular time. So paracetamol for a long time was considered the first line for OA. Especially for those people who cannot tolerate NSAIDs, but also a lot of our patients are old, the OA patients in their 70s, so you don't know about the kidney function and everything. But long-term suggests that sometimes patients abuse their acetaminophen or paracetamol, that's it. So they tend to have a bit of adverse effects associated with it. So some which should be used cautiously. especially people who are at high risk for liver injury. And a lot of people don't understand the association between paracetamol and alcohol because that can increase the risk for hepatotoxicity for these patients. And sometimes some of these extra strength, double strength, sometimes the patient may not be able to understand what exactly it is. So you really have to tell the patient, okay, the actual dose is 500 milligrams, 1,000 milligrams, how many times per day. Be very, very precise in how you talk to the patient because sometimes they may overtake because of pain and they don't actually overdosing. So a patient comes back. You don't put them on paracetamol, some topical NSAID, send for physio, still in pain. What next? So here comes the part where usually is normally a long debate in the clinic in terms of which supplement is good, what's not good, and everything. So a number have been tried and tested from the turmeric, ginger, glucosamine, chondroitin, and vitamin D have been tried. Turmeric has a bit of anti-inflammatory pain relief. It's generally safe without major side effects. But in terms of the major challenge with turmeric is that in terms of what exactly is the exact dosage, how to give it, best formulation is still not known. But it can be an adjunct, meaning an added medicine to the standard. But it should not be the only medicine the patient should be taking. In terms of glucosamine and chondroitin, a lot of the supplements have these things. There's been an up and up and up people in terms of whether it helps or doesn't help. I think early might have some benefit. In patients who are stage 3, 4, not that much benefit. Because I think at the end of the day, we sometimes as we doctors, we should avoid whereby you can see clearly the patient needs surgery and you're busy pumping them with glucosamine and the patient in the head is thinking, I will get better. No, clearly this is supposed to be a surgical patient. So I think telling them about it, tell them, hey, look, this one works better 1, 2, isn't it? 3, 4 might not work that well. If it's 4, I think just send them for surgery options with the best. Though in Kenya, I guess they're normally very hesitant about any surgical options. So in terms of vitamin D, a very interesting paper published earlier this year actually found that vitamin D supplementation will help, but not all patients. People who had vitamin D level between 12 and 43. Actually, there was a reduction in terms of the pain score for these patients, in terms of cartilage loss and deferred progression of the disease. So anything above 60 has some issues. So for patients who are not doing well, vitamin D, you could test and see if it's below at least between 12 and 43, you can clear and see, okay, this might actually be beneficial for the patient. So in terms of NSAIDs, usually the question, is it topical? We have the number that are available, or is it something oral? And a lot of time people perceive topical as non-medication, but topical can actually be used to reduce the number of pills patients take. Because like I said, imagine patient X has diabetes, has hypertension, has dyslipidemia, has gout, has rheumatoid, has OA, and a bit of pain. So sometimes we might use the topical as a way to lower the pill burden, but actually they help. So the thing would be choosing who to give, who not to give. Generally, the general rule of thumb, topical has fewer side effects. Fewer side effects, from especially the GI part, dyspepsia, diarrhea, anything in GI, typically it is better. But it's a bit effective, isn't it? But it has limitations because you have to apply it many times in a day. Joint penetration is here, not there. So it's something that can be more of an adjunct rather than a main for osteoarthritis. So in terms of the orals, at the end of the orals are still superior. There are a number of papers that have been done. As you can see from the graph here, the forest plot, you can see uh, those favoring treatment, actually, it's more, actually, it's obvious that it's better in terms of pain, in terms of physical function for these patients. But remember, when you're prescribing these medicines, the NSAs, you have to be aware about the potential side effects. Remember, you have COX-1 inhibition, GI stuff from the acid, reflux, ulcers, and everything. If you're blocking COX-1, 2, remember the cardiovascular and the renal aspect from sodium retention to AKI, strokes, myocardial infarction. So you should be able to, so then is just stratify the patients and use the NSAIDs as appropriate where possible. So how would you do this? Indications for NSAIDs. The first thing would be screen. Are there low risk for GI? If they're high risk, you probably want to favor the newer generation, the selective. If they're low risk, you could give with a PPI. If they're low risk, yes. If they have high GI risk, add the PPI. But also remember the renal function. Patients who have already AKI, it's very likely be safe to give them those particular drugs because yes, it could recover, yes, it could not recover. But also a lot of our patients are already old. So you can see already worsening to everything that comes with the NSAIDs. So remember about the risk of kidney involvement, upper GIT bleed, and the cardiovascular. So these are things that should be evaluated every time you see the patient. The UECs, look at the patient, are they high risk for stroke and everything? Because at the end of the day, you want the lowest effective dose for the shortest duration where appropriate. And in terms of NSAIDs, from experience, I want to learn that different NSAIDs respond differently. Other patients respond to NSAID. One, you're allowed to mix around and see until you get the one that works well for that particular patient. Remember potential drug interactions. Our patients are already using many drugs. Antihypertensive, the ACE inhibitors, IRBs, the kidney stuff is there, isn't it? Beta blockers, ECB, heart stuff is there. Patients antithrombotics, the risk of bleeding, aspirin and warfarin. The antidepressants, mood stabilizers, the drug interactions, they are there. The herbal stuff should also know what they're doing. The corticosteroids, GI stuff is something we should be aware of, the ulcers and everything. So in terms of guidelines, oral, like I said, for a short time where possible. You have the options of topical. Uh, Sometimes you may give intrathecal injections. Those short term is not something which should be done all the time because it has its obvious side effects from thinning of the cartilage and everything. So it's something that you can use for symptomatic, but not something that should be the mainstay of treatment. So in case there's no improvement, you could consider adding duloxetine. Duloxetine is something borrowed from the psychiatric ward. It can be used for not only for the depressive side, but also for pain management. We have a couple of studies like this particular systemic meta-analysis that showed actually there was some potential benefit in terms of for patients who had knee osteoarthritis in terms of pain, function, and quality of life up to 13 weeks. So it's something which can be associated. Remember also our patients have a lot of depression that come with the osteoarthritis. In terms of the dosing, up to 120 milligrams per day be enough. In terms of steroids, like I said, steroids is something you can give. This is a very nice paper. If you get some time, have a look at it. It was comparing guidelines for hyaluronic acid, steroids, platelet PRPP in knee OA. As you can see from that particular meta-analysis, they were saying the injections were fine in terms of the steroid, but like I said, should be used sparingly. In terms of the platelet-rich platelets, plasma, because they're saying it was very subjective, but also in terms of how much to give, when to repeat, what is the dose. These are more things which we don't have answers for. And it's something which the general concern for this particular paper was that it was uncertain. In terms of DMARDs, like we said, it's right now when we look at OA as an inflammatory, not just wear and tear. They've tried a couple of DMARDs. Methotrexate, one of the drugs that have been tried. In terms of the results, there are two particular trials. One of them looked at 10 milligrams per week, showed no benefit. Another did 20 milligrams a week, a bit of a higher dose. There was a bit of pain reduction at month 6. But there are a lot of questions about the study and everything. And it's something which there was no really consensus, but they said we need more data. They're saying that it can be used as of label. It can, but it's something which is open for debate. Yeah. So IL-1 inhibitors, IL-1 is one of the main drivers for osteoarthritis. Not promising. They've done a couple of studies, but the results are not that encouraging. So this is something still open for more studies. TNF inhibitors, the same. We have a couple in the market right now. Still not much, especially in terms of the erosive side and synovitis, which can come especially with the OA part. So SGLT inhibitors, something to think about. I know right now there's a lot of half and puff about these particular drugs, and they've shown some benefit, partly because of the weight loss and everything, but also due to its anti-inflammatory, antioxidant, and reduced production of leptin. So this is something which can be explored as a potential add-on treatment to what the patient is taking. So as we're finishing, I came across a very interesting paper that looked at hand OA. And they were talking about 10 practical tips on management of hand OA. And I think this can be applicable to all sorts of OA. And I think the first thing is that you should make the diagnosis clear to the patient. Number two, in terms of giving a positive, accurate message for the patient, avoid things like not sure and everything, and then avoid even using terminology like wear and tear. I know sometimes I've been guilty of that in the past, but it's not about wear and tear. There's more than about wear and tear, this particular patient sort of patients. Explain to the patient that OA is mechanically driven, but also understand that there's an inflammatory component for all of this. Remember to treat any concurrent condition. When you're choosing the medicine, remember they have a lot of comorbidities for hypertension, diabetes, depression. That also helps a lot. Hand exercises for hand OA, and this can be applicable to knee OA, another OA. That is not just medicine. We just have a bit of exercise in terms of for flexibility and strengthening and all that. Another thing is offloading mechanical. So looking for triggers. So one of the things to offloading the joint will be weight reduction and everything. For hand OA, putting the splints and everything will help this particular patients. In terms of analgesia, should be justified for persistent pain, and it should not be where we give all the patients all the time. Remember that also a lot of these patients, as they get away, age is a factor there. So don't ignore the menopausal symptoms that come with that particular age group. You should treat OA like a soft tissue injury. Remember that flares can happen. Today they're stable, they've done something heavy, have a flare. RICE approach helps. RICE basically means you rest, ISO warmth, compression, elevate. That helps. Then avoid saying that it's a single solution whereby take the supplement, you should be fine. Remember that it's multifaceted. Apart from the weight loss issues, we have the supplements, you have the physio, flexibility. So it's not just a one shoe that fits all. So as we come to the end, when you ask about what the patients take, it's very important because you need to know what exactly they're taking. Do they actually need those particular medicines? A lot of times, some of the supplements they take, there's an overlap with what they're taking. A very interesting story. I once had a patient who had come in with the diagnosis of psoriasis. It was very interesting. How she came with the diagnosis of psoriasis. When I looked at her, she looked almost past like, but I wasn't sure. I said, okay, send her for some lab tests. She had a few antibodies positive. I still sure, but I said, this is diagnosis. Skin biopsy of psoriasis, it really throws you off. So I was wondering, what are the odds you get psoriasis and lupus at the same time? I said, okay. So anyway, I said, what to do? This is a medicine that can work both ways either way. So we put on methotrexate, HCQ for the lupus, methotrexate can take care of psoriasis and the lupus. So we put her, about 2 weeks later, she comes back having a serious flare. Skin is all over the place, what. So she was blaming, because she also had epilepsy, so she was blaming the epileptic drug, the carbamazepine that could have sort of looked like an SGS, SOC10 syndrome. So we dug deeper, she said, but the mom came with a supplement. So she showed me the supplement. And the first thing I saw there was something called alfalfa. So for those who see lupus patients, know that alfalfa is a vegetable that can actually trigger lupus reactions. It's not available in Kenya, it's actually more in the States. So, and actually, when I saw the alfalfa, it's when I connected the dots together. So I sent off a second opinion for a dermatologist who confirmed actually what she was having was actually what? Lupus. So it's actually very good to know what exactly the patient is actually taking. But also, that because of the polypharmacy, a patient can take vitamin D in very many places. And even the calcium, the chondroitin, and it's just overwhelming the patient. And like what Dr. Adele said, adherence. Another thing is side effects. A lot of these drugs, people just take them and they know about the side effects. So usually for me, I tell the patient, if you're not sure, take a photo of the content, send to me, then I can be able to tell them, is it possible or not possible? But also the last thing is that cost. Those supplements are not cheap. I think supplements is one of the biggest booming businesses in Kenya right now. It's big and it's not cheap. So remember that our patients are doing polypharmacy. And like what Sarah said about drug adherence there also, remember that in terms of when you're prescribing and all, that is actually costly. So as we come to the last slide, OA is a public health issue, and BMI is one of the things that are driving it. Excess Tai Chi patient activity programs can help improve function, especially those with the knee and hip, which are the most common things that we see here. In terms of management, NSA should be short, sweet, where necessary. Remember that you have to certify the patients. Remember that there's a GA part, there's a cardiovascular part, there's a renal part. drug interactions, the hypertensive, like the ACE and IRB, can give some kind of triple whammy where you have kidney issues, the increased bleeding risk. I think they need to talk about the patient. Remember that also cognitive behavioral therapy, a lot of our patients are depressed. 20-30% of patients with OA have a lot of depression. As well as the pain that they're perceiving may not be directly attributed to the OA, but they can also get concomitant things like fibromyalgia. And the depressive part is what drives it. So cognitive behavioral therapy is very important. You tell the patient, tell them, okay, we have this, we need to change how we think about it. But also, like I said, like the paper which was published about initiating exercise, a lot of our patients, especially the elderly people, are very hesitant about starting exercises. They say, oh, all the neighbors look at me and I'm looking like running around the neighborhood like a mad person. They say, oh, what's going on there? So sometimes you really talk with the patient. We have alternative things like acupuncture. There's something called Lunga Best that helps the back staff. The things is I listen. So I usually tell them it makes sense to continue. But I think the important thing, like what Nakshara said, is just engage with the patient. Remember that you don't engage with the patient, they don't take the medicine. And some of these who don't take the medicine, they come say, oh, side effects, you do this, or this, you do that. And I don't know what exactly that is. So you really have to have an open conversation with the patient. And I think we're done. Thank you.
Yeah, so thanks a lot, Dr. Kalman, for that. So for those of you who are with us, we were having two talks to celebrate World Arthritis Day. World Arthritis Day was on the 12th of October. This talk has fallen today because it's a weekday today. We've had two conversations about patient adherence, and we've had another conversation, updates on osteoarthritis. So Dr. Genga, I'm just going to jump into a few things which have come up in the chat. We'll see whether we're able to answer or not. Some of them have to do with what you might have discussed about risk factors or potential attributable factors to osteoarthritis development. I'll just combine some of them so that you can see how to answer. There are some questions to do with some of the diseases that you might have mentioned as associated with or are commonly found with. So there's a question about asthma, that how does asthma increase the risk of OA? I don't know if you had mentioned something like that. Or why are the atopic conditions associated with arthritis? There's another one which has to do hypertension. Why is hypertension prone to OA? And the other one has talked about these comorbidities like depression, hypertension, diabetes, dyslipidemia. Was the person is asking when studies were being done around the associations or the comorbidities existing in patients with OA, was it just within the OA population, or was it thought to have been compared to the general population and was found to be higher? So just see how you can manage those ones faster. And then I'll mention to the participants that there are some individual questions about individual problems in patients that we unfortunately are unable to handle in a forum such as this. So please understand if we cannot answer an individual question about an individual patient. Sometimes when you haven't assessed a patient and haven't had a discussion, it's difficult to answer the question. So Dr. Eugene, just around those issues of associations, or are they really cause effect, or are they just associate, yes, go ahead.
So thanks for the question. I think I'll start with the risk factor questions. If the data is not that concrete, though we found a few associations between asthma and atopic, and it's probably potentially they're saying it's more with the inflammatory cascade. In terms of, like I was saying, like the obesity, we avoid seeing this by entire. And like the slide I showed about height activates the inflammatory cascade. So potentially that could be what is driving. And number two, in terms of comparison with the general population, unfortunately, they didn't do. I know for Abdi, they didn't compare. Even the one that was done by Nyakwara at Moi, they didn't actually compare. What was just interesting was how it was different, because the one for Abdi had more knee, the one for Nyakwara had more hip. But in terms of why the difference is a bit hard to tell why. Maybe genetics and what you see on this side and all that is a bit hard, because most of the time we actually see more knee than hip. Hip is actually more seen people do more manual work and more mechanical stuff. Maybe you can assume maybe in elderly they do more of that, but it's hard to tell, to be honest. I think that's about it. Let me see. Was there anything else? Have I captured everything?
There was something about, someone was asking about the data from MTRH. Let's see. Any explanations to the difference in the KNH and MTRH studies regarding the most commonly affected joint in OA?
Oh, that's what I was trying to answer. It's a bit hard to say what the difference was. Okay, the studies were done in different populations. That's number one. But to be honest, it's a bit hard to tell. To be honest, but maybe you could say maybe although there's more of an agricultural town, there's more manual work there. It's a vineyard which is more of commercial and not that manual work. But also sometimes the population we see in the clinics, you can't really tell. So it's a bit hard to say why, to be honest. That is a bit hard to say why. That's something which can be an avenue to have a proper study on going forward. Yes, thank you.
Okay. Yeah, there are some questions which I think you handled during the talk, which some of the patients are, some of the attendees are still asking, though I think you handled them. So I think we'll just keep those. I think you handled the role of steroids in osteoarthritis, you handled the risk factors, and you handled how to diagnose. I think the issue of hypertension, you also handled issues of drugs. So I'm going to leave those ones out. Do you have any comment on this question about climate or weather and its whether it has an effect on the severity on the treatment course of osteoarthritis? Can climate or weather, this issue of cold weather, blah, 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 with osteoarthritis? Any comment?
So not much, to be honest. It's a common question I get being asked because I think the assumption is that if I come from a cold area, that there's more arthritis. But usually I tell patients if that was the case, then every person in the North Pole or the South Pole should have more arthritis there because of the cold weather. I think it's more to do with maybe how they present. I think with the cold weather, the symptoms are more severe. I can't remember the certain hormones that swell up and everything, the cytokine profile during when it's colder, that may be what is driving more pain and the quality of life. But in terms of whether it has a direct cause, not really. OA is multifactorial. So I think for this, it'll be more of how it presents. In terms of the treatment course, patients tend to get better during warmer weather. I think partly because it's warmer, the muscles are more relaxed and everything. But it's not just the weather. It's a multifactorial thing. So it shouldn't just be attributed just to one particular factor. Yes, thank you.
Yeah, that's fine. And maybe just to add to it, I think there's some people who have theories around how, when the weather changes, there may be changes in the barometric atmosphere may affect intra-articular hypertension or pressure. But these are also just theories and thoughts around those issues of why are my symptoms different when the weather pattern changes. Yeah. Okay, so I think most of the other questions you handled during the talk, and maybe if people were listening, they would have understood. And I think because of time, we can't go over every single or repeat every single issue. I answered one or two in the chat. I think maybe we leave it at that. What I want to mention to the KNH, the ones who are managing, I think there are a few people who are saying that they are wondering about receiving CPD points and they're wondering about slides. So I think I'll leave the KNH, the host who will handle that issue later. Do you have any other final words, Dr. Eugene, before we close this session?
Just to thank NH for giving us this opportunity. I think arthritis is commonly neglected. People see as a very boring disease, especially osteoarthritis. But there's a lot going on in terms of the research, and a lot of things are coming. I think for OA is more prevention. Prevention is better than raising that point where you get to stage 4 and everything. So just thanks to the attendees for coming today. I think maybe due to, I'm seeing so many questions, I think maybe it's a challenge to us as a trauma to organize more sessions through Kenyatta, to see how we can empower the public case. Thank you.
Okay, so thank you very much, all of you, for attending. And yes, apologies that we cannot answer each and every question because this forum usually has a very large audience and sometimes it's difficult to go through every single question. And some of the questions, of course, Dr. Genga had handled during his talk. But we do appreciate your attending this session and we hope to continue with more educational sessions in the rheumatology field. Thank you, all of you, and have a good evening.